So I am talking about the place of plasma exchange, therapeutic plasma exchange in leptospirosis. Commonly practiced in the leptospirosis cases, is it beneficial or not? First of all, that I would like to thank the CME committee as well as our new president to giving this opportunity to convey the big message to our doctors, right? So thank you very much giving me the opportunity to talk about the leptospirosis, that our role in doing the therapeutic plasma exchange. So last 6-month period, actually the data is not much correct, but average 68 referrals we received last 6-month periods, 68 referrals, but we have performed only 50 cases, only that we performed the therapeutic plasma exchange. That 43 cases recovered from 1 or 2 therapeutic plasma exchange, yes, and then 7 cases were death. That patients are complicated with the severe pulmonary hemorrhage, acute kidney injury, myocarditis, septic shock, and there are 2 patients, they had severe CPK levels, and then CPK levels. There are unusual presentations with ICU Dr. Dinisha also agree with me, 2 cases with unusual presentations, right? And then most of the death patients, they came in late presentations. So we performed more than 4 to 5 procedures carry out for these patients, but unfortunately we can't save their life. Then another important thing that I convey the message to Dr. Niranjana, you know that our one kit, right? One for the one patient we are doing the 1 or 2 procedures. Our one kit cost is 150,000. 150,000 one kit. This is no added the material cost, only for kit cost, right? And then the total 91 therapeutic plasma exchanges were performed during last 6 months of period. You can see how much we spent from the transfusion services, right? So I think better Dr. Niranjana, you convey this message. From your presentation, you said 3% of them taken the prophylaxis, but not that they infected with the leptospirosis. But in the doctor, one said in the one study in the army group, they significantly improved with the doxycycline. I think because I talk all the patients that I refer to the plasma exchange, but I came to know that they are not much aware about, and they know how to take that. Sometimes they say they are taking, but not in the correct time and correct period. Only 1 dose, 2 dose, that's enough. They thought it is it. I think it's better to convey the proper instructions to the farmers, our farmers. All are young patients, around 30 to 50. They are a productive age group in our community. We are losing them. So better you have to address on these sensitive points, right? So I think doxycycline is not much expensive. You can see that how much we spend for these procedures. Yeah. Then I come to this my presentation. Actually, already everybody is there. These are zoonotic infections. That I skipped these first 2 slides. Our farming community has a high risk of contracting the infections, and even bathing in the rivers and lakes also, and the casual exposure to wet soil carries the risk. And then in the epidemiology already we have discussed that it all present in all continents except Antarctica, more prevalent in the tropical countries. 60,000 deaths worldwide reported. Most host animal, they carry the leptospira in their kidneys, and they shed the pathogens in their urine. Human become contacted directly as well as indirectly, mode of transmission. According to the study done by WHO in 2015, Sri Lanka named as a leptospirosis for hyperendemic country. This is the clinical manifestation. There are two ways biphasic illness, that is septicemic phase and then followed by the immune phase. The immune phase, that patient presented with aseptic meningitis, various disease, pulmonary hemorrhage, ARDS, and then shock with multi-organ failure. I am not going to talk about much. Let Dr. Numan that elaborate this clinical presentation. And then multi-organ involvement frequently present with the liver and the kidney, and then pulmonary symptoms that may appear after 4 to 6 days after the disease onset. Pulmonary involvement vary with the subtle clinical manifestations to the severe pulmonary hemorrhage syndrome. This is at this point that the patients refer to me for the doing the possibility whether we are doing the TB or not. The reported mortality following the SPHS is about 50 to 70%. SPHS is believed to be a major form of death in the leptospira infection. Pathophysiology, come to the pathophysiology of the pulmonary hemorrhage. Actually, the leptospirosis pathophysiology is under investigation, but they have says two mechanisms are involved in SPHS. What are the other one is the toxic mediated mechanism, other one is the immune response by the host. Toxic mediated mechanism, toxic mediated capillary vasculitis develop, and then it causes for the lung hemorrhage. Their outer membrane proteins are possible toxins related to leptospira pathogenesis. Toxins activate the vascular endothelial cells to increase their adhesiveness for the granulocytes as well as the neutrophils. And then there's an inflammatory process set up, and then that can cause the systemic as well as the local inflammation in leptospirosis. There are two in the other mechanism, immune response of the host. They are major contributing factor. Here, the dysregulation of the immune system of the host. Dysregulate their immune system can cause HPHS. And then here, antibodies, IgG and IgA, especially IgM and both two antibodies that against the pathogens, lipopolysaccharides involving here immunoglobulin are deposited in the alveolar endothelium as well as in the alveolar space, especially in the pneumocyte 1 and 2, and they are that leads to the necrosis of the pneumocytes, and that it causes to the HPHS. This is the pathophysiology of mainly in SPHS. The organ damage also due to the immune response to the pathogens by the and dysregulation of the immune response, that here that overproduction of the cytokine storm that leads to the involvement. Anyway, that genetic factors also are involving, right? Right, we skip all these. Actually, in this, then in the chest X-ray, right? Mainly the patient presented with the hypertension and all that he explained. That I come to my point because before my point, I want to explain that why we are doing the plasma exchange. That's why I do in the immune-mediated response, because otherwise no point of doing my part without getting the correct. That's why I sorry for my anyway. That chest X-ray, you can see small nodular pool cotton wool appearance in the chest X-ray, and then then come to the what is TB. TB is a procedure that we have to perform for the various so many indications. For the burden for these days is a lepto, and we are doing about per month about 60 around 60 average procedures. Out of them, majority of the procedures we are doing for the leptospirosis. And then here, that selectively removal of the substantial proportion of one or more component that can cause the disease, and then return the remaining part of the remaining component of the blood to the patients. Here that we use we withdraw the blood from the patient with mix with the anticoagulant and to the rotating ball of the centrifuge. That according to the density, that most of the pathogenic substances present in the plasma, that we discard the plasma, rest of the products go back to the patient with the replacement fluid. Sometimes we are not giving the replacement fluid. Therapeutic plasma exchange that we do there. There are automated machines are available. There are two mechanisms that involve in the TP, centrifugation and the filtration. Our machines that they have a centrifugation method. And there are these are the machines that is available with us. They have intermittent, it has intermittent flow centrifugation and the continuous flow centrifugation for the depending on the patient hemodynamic status that we select which machine we have to go for the plasma exchange, right? And then there are indications that for the TP that classified according to the ASPA guidelines. So in the class 1 and 2, class 1 there are disorders for which apheresis is accepted as a first line therapy, but other or as a primary standalone treatment or in conjunction with the other mode of treatment. There are so many indications, Guillain-Barré, myasthenia gravis, many indications are there that we have the transverse meningitis and then neurological, hematologic, renal, lot of investigations under category 1. These ASPA guidelines, here for the studies concerned in Sri Lanka, one study conducted in 2015 to 2017, they suggest the possible better survival rate among the patients who receive the TP in addition to the standard therapy. And here, survival rate was higher when the TP is performed within the 48 hours of detecting the SPHs compared to the patients in the late presentation. Please, when you suspect SPHs without delay, refer to us anytime in the 24 hours we are functioning that to do the plasma exchange, right? Then I go through the patient presentations, clinical and laboratory, and we'll decide whether we have to go over the plasma exchange or not. And then the ASPA guidelines still not mentioned there. TP is the indication for the leptospirosis is the indication, the SPHS is indication for the plasma exchange because these guidelines indications are most that prepared by the Anglican Society because they don't have that lepto infections. Right? So there are some studies that is conducted in Sri Lanka. Currently, leptospirosis in the pulmonary hemorrhage, currently the mainstay of treatment, can suppress the host immune responses rapidly with the good safety profile. That will remove the circulating antibodies, immunocomplexes, endotoxins, that reduce the cytokine storm, as well as catabolic products, including the bilirubin. And then we consider the replacement fluid, FFP as a replacement fluid that replace the missing enzyme ADAMS 13. You know the function of the ADAMS 13 that break down the high molecular weight polychloride factors to monomers, and also that replace the protein 3-1-S. So it's FFP, the replacement fluid, 100% replacement. This depends on the renal function of the patients that will decide for the consider in the therapeutic plasma exchange. This is very important. I think this slide is very important for the registrars. And then these are the indications for TPA in Leptospira pulmonary hemorrhage. Any three of following present in suspected or confirmed cases without delay inform to me, right? Patient is tachypnea. Tachypnea means that respiratory rate more than 30 per minute, and then arterial hypoxia according to the ABG evidence, increasing the oxygen demand subtly to maintain the SpO2, sudden drop of SpO2, hemoptysis and chest X-ray, they are so suggestive of the pulmonary hemorrhage. In the preparation of the TP is an emergency procedure. Get the informed consent, send the sample to the blood bank, insert the vascular catheter, 14 gauge or 16 gauge, that depend on the patient's body weight. That my protocol is available to you. in the blood bag. When the referral comes, we send that is given the which gauge that should use for doing the vascular. Otherwise, or here and there you are calling and asking right? It is all the instructions in the protocol, right? And then at the same time you insert the IV cannula. Don't send the patients to ICU without putting the cannula. Sometimes you are not put the vascular catheter, you are send the patient to the ICU. ICU, we have a bed. Thank you very much, Dinisha, to allocate the bed for the blood bank procedures. And then otherwise, ICU people also getting embarrassing that because we are without proper preparation of the patient, you are sending just send the patient to the ICU for the procedure. We can't do that, right? And then at the basic investigation should be available. These are the basic investigation. This is normally we are doing. And then that need to assess the hemodynamic stability of the patient before start the procedure. So blood pressure that we concern, because I have to maintain the mean blood pressure about 65, and with or without inotropic support or number or the doses of inotropes, but the blood pressure is dropping, that we can give the inotropes, norad infusion, and also at the other vasopressin or adrenaline, and then we maintain the blood pressure. Systolic blood pressure 100 milligrams per mercury more than is enough, adequate for the procedure. Otherwise, high blood pressure, there's a risk of further bleeding. The hemoglobin level is less than 7 grams. We have to think about the RCC transfusions, but before the procedure, or we can give it during the procedure. And the treatment plan that we do as started as early as possible for the better outcome. Frequency daily we do perform with the replacement fluid is FFP. We process 1 to 1.5 total plasma volume, and then remove the plasma. And under continuous monitoring of the vitals with the automated method, daily assessment of the patient need to do the further procedures. Assess the response by reducing the oxygen demand, stable the HB levels, reduction in the inotropic support, and the improvement in the renal functions with the blood urea and the serum creatinine levels with a good urine output, and improving the chest X-ray, disappearance of the ECG changes with the myocarditis aggregation, and then the platelet, improvement of the platelet. Poor prognostic signs are there, late presentation for the specific treatment because of the delayed admission, delayed referrals, delayed arrangement for the TP. Most of the time, delayed arrangement for TP. So in other one is the severe and multiple episodes of hemorrhages, no renal involvement after several procedures, coexisting severe myocarditis, evidence of multi-organ failure, and history of heavy smoking. Way forward, need properly conducted randomized control trials to assess the effectiveness of the TP. These are my references. Thank you very much for giving us.